calling me.
Yeah.
Sir, I think we can start now. The problem has been fixed.
Okay. Should we start from the beginning?
Yes, sir. Let me check with Simriti also once again. Simriti, are you here? Can we start, Simriti?
Yes,
Okay. Oh, thank you. I think it is echoing.
what's echoing there? I can't hear any.
Anupaya, it's echoing here. Hello? Hello?
That highly risky for individuals. Why are we worried about it? Why is the whole world in such turmoil? Because of the outbreak and transmission and spread of the virus. The answer is that in an immunological sense, almost all of us across the world appear to be inexperienced. Naive is the word that immunologists like to use, but really, immunologically inexperienced for all practical purposes with SARS-CoV-2. As a result, SARS-CoV-2, which has its own abilities to spread rapidly, is going to spread and has spread across the world quite rapidly in immunologically inexperienced populations. And the result is that the spread is so rapid that in any given, say, month, the number of infected people is so large that even if a very small minority of them, you know, between 5 to 10%, become severely enough sick to need hospitalization, those numbers at one given time are so enormous that they will overwhelm our hospital systems. And if that happens, then people will begin to die needlessly. People will begin to die not because they had a lethal disease, but because we could not provide them sufficient health care. And that is why SARS-CoV-2 and COVID-19 are a major community risk rather than being individual risk. This is the reason why we need to stop being afraid of the virus for ourselves, each one of us individually. We need to be worried about and careful about the virus on behalf of the community at large. That's the first general point that I think all of us need to keep in mind. The second general point, which we will come to in somewhat more detail, is contrary to anything that anybody says in advertising, at the moment, there are no proven specific treatments for SARS-CoV-2. This does not mean that there is nothing we can do. There is a great deal we can do for people who are severely ill with SARS-CoV-2. But there isn't a specific drug. There isn't a specific, let me use the term the WHO used, silver bullet. Although silver bullet and vampires and Dracula and bats, and it all comes down very weirdly to SARS-CoV-2. So let's not go there. There is no such oxyrilage for SARS-CoV-2 specifically. There's all sorts of drugs being talked about. None of them has so far been unequivocally proven to be dramatically useful. So whatever we do is going to be supportive therapy. It is important. Its absence kills people, but it is supportive therapy. The third general point I'm going to make as a takeaway for people who are already anxious about the time, because we've spent quite a bit of time in technical difficulties. And therefore, I'm simply going to summarize my very last point that I will make, which is there a vaccine currently? No, there isn't a vaccine. Will there be a vaccine? In all likelihood, there will be a vaccine. How soon will the vaccine be available to people at large in India, particularly all people, which means underprivileged people, poor people, and so on? That is an unknown, and it is an unknown not because the science and technology involved in making the vaccine are a bottleneck. It is because the manufacturing and the politics and the economics of vaccine manufacture and distribution are going to prove the bottleneck. So that's my going to be my last point. Anybody who wants to leave can quite happily leave and not worry about the detail. That said, let us start thinking about how the virus gets in, and from that point, let us see if we can track what the body does in response to the virus. So the virus is transmitted, SARS-CoV-2, the virus. Please, can we not call it corona? Coronaviruses are a very large family of viruses. And to tar every poor member of the coronavirus family with the same brush because of the misdeeds of SARS-CoV-2 is a little unfair to other coronaviruses. So let us refer to it as SARS-CoV-2. I grant you that it's an unwieldy name for a virus, but hey, SARS-CoV-2 it is. So SARS-CoV-2 comes into me by droplets. So somebody who has an infection, let us say I went into the jungle, there is a bat or a pangolin or a similar wild mammal where there is a variant coronavirus that is capable of infecting humans. And I come into contact, I breathe in droplets from an infected animal. The virus comes in. The virus is capable of infecting me. How does the virus come in? The virus comes in through a droplet. Now remember that while virus particles are in a droplet, there are no active metabolic processes going on in the virus particle. The virus is not generating energy, the virus is not using energy, the virus is not doing anything with enzymes. There is no dynamic process going on in the virus particle. So the virus particle, if it is damaged, has no repair mechanism. So it has a very short, relatively short time window within which to begin its life cycle. At the moment, as a particle, you could almost say it's non-living. In fact, some people say that it is non-living. So the virus particle comes in and it needs to get into my cells in order to start its life cycle. How does the virus particle get into a cell? So the virus particle, for those of you who have seen Star Wars, the virus particle is like the Death Star, which is for those of my age who are not quite sure what Star Wars and the Death Star is. The Death Star is a sort of manufactured planetoid meant for war. So there are all sorts of shapes on the surface of a roughly spherical virus particle. One of those molecular shapes is used to dock onto a cell surface molecule, and that allows the virus to stick to cells. And that's the first step in getting into cells. And as the viral RNA, this particular virus doesn't use DNA, it uses RNA. As the viral RNA gets into cells, two things begin to happen. One, the viral RNA takes over the biochemical processes of the cell, and rather than making cellular proteins and related molecules, it now begins to manufacture viral RNA and viral proteins and assemble copies of virus particles. But at the same time, the viral RNA is sensed by cellular processes, and the cells begin to have a response triggered in them that you could say is antiviral. And this is the first immune response. This immune response does not know which particular virus has come in. It will respond roughly similarly whether SARS-CoV-1 has come in or MERS-CoV has come in or SARS-CoV-2 has come in. But it senses that there is a virus. It senses it by virtue of the RNA shape or the RNA structure and so on and so forth. And what that leads to is the cells making proteins that prevent the virus from taking over the biochemical processes of the cells that virus particles infect. And this is the interferon response, and it is the interferon response that is the first stage of an antiviral immune response. Keep in mind that these are going to always be in contention with each other. The virus is getting into cells as virus particles. Virus particles are leading to assemblies of large numbers of viruses, all in the respiratory tract, in the lining, in the cells lining the respiratory tract, in the breathing tubes, all the way down into the lungs. So two things are likely to happen. One, there might be enough interferon to prevent the virus from growing any further. We're really not sure whether this really happens or not, but it may well happen. If this happens, you're going to have so mild an infection that it may just as well be an asymptomatic infection. On the other hand, if the interferon responses are not very large, or if on the other hand, you have been in a closed recirculating air-conditioned room with a large number of people, some of whom are infected, talking loudly, singing, cheering, you're been exposed to a very high dose of the virus. That means that in your breathing apparatus and lungs, there are large numbers of locations where virus growth has begun. If that happens, then the interferon response is unlikely to be able to control the virus completely, and the virus is going to begin to expand. When this happens, what you end up having is the virus beginning to be sensed more and more, particularly by specialized cells of the immune system, and they begin to do something interesting. What they begin to do is to secrete, is to make proteins and related molecules, all of which attempt to quarantine the virus. All of us are familiar now with microcontainment zones, and effectively the first immune response by specialized cells of the immune system to a virus infection that they sense is to try and contain the infection. More correctly, the response that they make ends up containing the infection. This is great. Infection containment means that you're trying not to let the virus spread too much, and this is very useful for the body. But think about what is happening. So think about, for those of us who are in college, think about the most common and obvious example of containment of infection that we are all familiar with. We are all familiar, unfortunately, with acne, zits. And what that is an infection of, say, the hair follicle by staphylococcal bacteria. There is an immune response, and the immune response contains the infection locally. This is great because the infection doesn't spread, but it's also not so great because you have a Z. And we all know what just how much grief that creates. So effectively, what is happening? So to put it in polite terms, what is happening is my skin in that particular contained location in that microcontainment zone is really not working as well as skin ought to work. Exactly the same thing with virus locations in the lung, where in the airways and the lungs, where microcontainment zones are set up by inflammation. Sure, you are containing the virus, but you are also reducing function. Now, if this happens in the lungs on a large scale, then obviously lung function begins to be hampered. And it is when lung function begins to be hampered that you begin to have more and more serious illness with SARS-CoV-2 infection leading to COVID-19. So the first symptom that you can easily explain is cough, because the virus is growing in the airways, there is inflammation going on in the airways in response, and you therefore have airway irritation and cough. The second is you become breathless, and that's because lung function is sufficiently hampered that you're not getting enough oxygen, and you're getting therefore breathless, which is why the pulse oximeters, which is the other thing that the pandemic has taught us about, pulse oximeters, which tell you how much oxygen you're getting into your system, begins to show that your level of oxygenation is falling, and people with levels of COVID-19 illness that are concerning begin to have oxygenation levels falling well below 90%, and sometimes as low as 40-50%, quite astonishingly low levels of oxygenation. So that's the second part of how the immune response and the virus crosstalk with each other. Here's what happens next. And what happens next, we are going to think about in two different ways. One is, as the virus load grows, because remember, the viruses that come out of one infected cell are going to stick to and enter new cells, and each virus particle getting into one cell is going to lead to hundreds of new virus particle copies being made and released. So the growth trajectory of the virus is very, very steep. So the virus load is growing and more cells are getting infected. There is a lot of viral material. One of the ways in which the immune system can respond to this kind of outside material, the virus material is not stuff that the body is familiar with, that the immune system is familiar with, and the immune system has responses to unfamiliar material. And these responses, unlike the first category of responses, which are the inflammation and the interferon responses, this second category of responses are responses where the immune system finds in its cells an exact match for viral targets. So now, SARS-CoV-2 specific responses can be triggered. These are responses that will be very specific to SARS-CoV-2. They may not even be triggered by SARS-CoV-1 unless the molecular shapes are common between SARS-CoV-1 and 2. So these are very specific responses. The immune system has to start with very few cells of this specific kind. So it takes a few days for the immune system to expand this cell number that specifically recognizes these particular targets and to bring their responses, the responses of those cells, into play. And those responses are in two categories. One, the most obvious and well-known ones, are that we make antibodies that are specific against SARS-CoV-2, for example. So we begin to make antibodies. Now, how do antibodies help in preventing the expansion of the virus population? Remember what I said. You have a virus particle which comes and sticks to the cell. So the sticking is through a very specific interaction between a shape on the virus particle and a shape on the target cell. Now, if the immune response has made antibodies that specifically bind to this particular shape on the virus surface, then that shape can no longer come and stick to the cell. And if that happens, then you're preventing virus particles from sticking to cells and starting their life cycle. Effectively, you're cutting virus life cycle short, and you're therefore gaining control over the expansion of the virus population. This is a neutralizing antibody response. But keep in mind that this is not something that the immune system does with thought out intention. This is simply a response of the immune system, a sort of biochemical instinct, if you will. And therefore, the immune system will make responses, will make antibodies against a number of different shapes on the surface of the virus. All of those are not going to be neutralizing. And therefore, all antibodies are not going to be neutralizing or protective antibodies. And I'm saying this in the context of the newspaper report of the Sero survey in Delhi, where X percent, 22.48% of Delhiites are seropositive, meaning that they have antibodies against SARS-CoV-2. This is extremely useful information, and it is possible that a large fraction of these 22% people are indeed additionally protected against the virus by having neutralizing antibodies. But the test that is done is for total antibodies, not specifically for neutralizing antibodies. And therefore, we don't know for sure that all of them are protected. This is something to keep in mind. The second antiviral response that the specific immune system makes, the so-called adaptive immune system makes, is that made by T cells. And T cells make two kinds of responses. One is they contribute to the inflammatory response so that they provide better and better containment. And we will come back to this containment by T cells in a minute. But the second kind of response that T cells make is they can recognize infected cells quite early during the infection of the cell by the virus, so that they can kill an infected cell before virus copies are assembled. And if an infected cell, so if the virus RNA has come into the cell, it's getting its act together, it's trying to make copies of virus RNA, virus protein, by taking over the biochemistry of the cell. And if in this process, the cell itself is killed off, then the cellular biochemical processes stop, and the virus simply ceases to exist. So the virus runs into an existential roadblock, and you stop the growth of the virus population. So killer CD8 T cells, therefore, are important from this point of view. CD4 T cells, which contribute to the inflammatory containment, run into exactly the same difficulties that the ones we talked about earlier, which create inflammation-generated microcontainment zones, run into, which is that the activity is useful, but if the activity goes on in large numbers of locations, then the entire function of the tissue comes to a halt. It's exactly like a city. In a city, if you have huge numbers of microcontainment zones, the rest of the city stops functioning. Exactly like that, you have huge numbers of inflammation zones in the lungs stop functioning. And then you have major turmoil. And that turmoil is in two different directions. Number one, the chemicals, the macromolecules, the large chemicals that these cells are using to create the microcontainment zones, there is so much of those chemicals, those macromolecules made, those inflammatory proteins made, they're called cytokines, and everybody's heard the phrase cytokine storm, that they begin to spill over from microcontainment zones into the body at large, and then they begin to have effects in distant locations in the body. And this is one component, one major component of the cytokine storm. And the second, of course, is that the virus begins to escape from microcontainment zones and begins to infect other cells in the body. Is this possible? Yes, it is possible, because the target that this particular virus, SARS-CoV-2, uses to stick to cell surfaces is a target, is 2 angiotensin converting enzyme 2, which is expressed by a very large number of cells in very many different tissues. So the virus, in theory, can infect many cells in the body. And this is where life gets extremely difficult for the ill person and for the physicians, the nurses, and the nursing aides trying to help this person, because now it's not simply the virus in the lungs that is the problem, but the inflammation that is spread throughout the body in the cytokine storm, and the possibility that the virus is growing outside the lungs in other places in the body as well. So this is the trajectory. Remember that the virus is really not greatly interested. We shouldn't talk about viruses as though they have intentions. So let me put it in evolutionary terms. The virus population derives no survival advantage from infecting other cells in the body, because it cannot spread to a new host from those cells. It can only spread to a new host from the cells in the respiratory tract, because virus particles can come out into the inflammatory fluid of the respiratory tracts. I'm going to cough, I'm going to sneeze, and droplets are going to go out, small droplets, large droplets, micro droplets, nano droplets, whatever, and all of them are going to be laden with virus particles. And that's how the virus is going to spread to a new host organism. And that's how the virus population is going to survive in the ecosystem. So that's the interplay between the individual host and the virus. What can we do about this? This is what brings us to the idea of, let me use the term now, drugs. Can we stop the virus? And this is a question that's quite commonly asked. We have antibiotics against bacteria. We have literally hundreds and hundreds of antibiotics against bacteria. Why don't we have hundreds and hundreds of antivirals? So think about how bacteria grow versus how viruses grow. How do bacteria grow? A bacterium that is ready to grow uses its own biochemical processes and divides from 1 into 2. And then 2 become 4, and 4 become 8, and 8 become 16, and so on and so forth. In this entire process, the bacterium has used its own biochemical processes. Contrast this with how I described the virus grows. The virus particle by itself cannot grow. It cannot divide like the bacterium divides. It has to get into a cell over cellular biochemistry in order to make virus copies. This means that if we want to interfere with this process of growth for bacteria, we've got lots of targets, because we can use the bacterial biochemical processes as targets to interfere with. Bacterial biochemical processes that are different, sufficiently different from our own cellular biochemical processes, so that the process will work against the bacterium but will not work against our cell processes. And that's an antibiotic. For the virus, there are far fewer processes, which is why so many of the antivirals that are currently available, primarily with HIV, address only a very small handful of viral biochemical processes, viral proteases, viral DNA RNA polymerases, and that's pretty much it, more or less. This is why making antiviral drugs is hard. It's therefore no surprise that antiviral drugs for SARS-CoV-2 and COVID-19 have been as hard to make and have proven as difficult to show efficacy for as antiviral drugs for pretty much anything else. But let me remind everybody of a second point about antiviral drugs, which is, I don't know how many people have any experience with shingles, with herpetic outbreaks, blisters on the skin. There is a very good antiviral drug available for that. It's called acyclovir. But if acyclovir is going to be useful for the shingles outbreak that people have, it has to be used very, very early. For people who have been exposed, unfortunately, to herpetic lesions and shingles, they will remember that as soon as you begin to have even a little sense of skin discomfort, you have to apply acyclovir. You have to take the tablets. Then it works. But if you apply it after the inflammation has already resulted in very painful blisters, it helps, but it doesn't help as well as, for example, antibiotics help, even when you have severely ill people with bacterial infections. There is a difference between the biology of severely ill bacterially infected people and severely ill virally infected people. So we need to stop longing for, expecting, and wishing an easy magic antiviral bullet. So, what sort of antivirals are there? So, the obvious thing is interfere with viral protease, viral RNA polymerase, which is what all these, some of these drugs, the remdesivirs, the favipiravir, the ritonavirs, lopinavirs, all of this, the something or the other virs, all of them do that sort of stuff. But here's what you can do. Remember what our antibody response does? It does not let the virus particles stick to cells. और फिर ना रहे बांस ना बजे बांसुरी. If the virus particle cannot get into the cell, then everything downstream is not going to happen and there is going to be no growth of the virus. So can you have antibodies which will interfere with this? In effect, the question is, can you give neutralizing antibodies to people? And this is the basis of the currently much discussed and in vogue plasma therapy. You can take antibodies, you can take blood, you can take serum, plasma, from people who have recovered from SARS-CoV-2 and COVID-19. You are assuming that they have neutralizing antibodies. If you don't test for neutralizing antibodies, you don't know for sure whether they have neutralizing antibodies and how much neutralizing antibody they have, which is why plasma therapy, when you transfer plasma from a convalescent person into a sick person, is always a bit of a hit or miss wishful thinking therapy. Because by and large, we don't test for neutralizing antibodies. But that's the basis of plasma therapy. So rather than doing plasma therapy, isn't there a better way of doing this? Can't I make a defined antibody that interferes with SARS-CoV-2 binding to targets? Yes, I can make monoclonal antibodies, and we can make monoclonal antibodies as a therapy. People may be familiar, just as the antiviral drugs have the suffix vir, as in remdesivir, lopinavir, ritonavir, and so on and so forth. All monoclonal antibody drugs have the suffix mab. So, tocilizumab, lopinizumab, and so on and so forth. I forget. There's all sorts of weird names, but they all end in mab. And the mab stands for monoclonal antibody. So can we make monoclonal antibodies against SARS-CoV-2? Absolutely, yes. Is anybody making and selling them? There are people who are trying. And it's a little surprising and interesting why they haven't been more widely tested already and they haven't been made available already. And that will bring us towards the end in another 5-10 minutes, to the issue of the political economy of the COVID-19 pandemic and how the immunity to SARS-CoV-2 intersects with the political economy of the COVID-19 pandemic. So that said, let us therefore come to the next question in therapy, which is, forget about the virus. It is the cytokines and the inflammation that are killing people. Can we do something about that? Absolutely, yes. What is the simplest thing we can do? What we have done for these kinds of systemic inflammatory illnesses by any infection. We are quite familiar with this state in its very diverse nuances of manifestation. By and large, we call it different kinds of septic shock and the cytokine storm situations. So what can we do? We can neutralize the circulating signals for inflammation, which shouldn't really be circulating because they should be functioning only in the locations where they are required, and they shouldn't be circulating all over the place. Too much is being made and it's flooding the system. Can we neutralize them? Yes. How? In a variety of ways. We know how to stop inflammation. We have very blunt hammers as drugs with which to stop inflammation. The most dramatic hammer that has been shown in a proper clinical trial in the UK to be very effective in improving outcome in severely ill SARS-CoV-19 patients is corticosteroids, is dexamethasone. The trouble is, there are always good effects and bad effects to be balanced against each other. So since there are cytokines that are creating inflammation, we also have monoclonal antibodies that are targeting not the virus, but the cytokines. And tocilizumab that is being tested and all the other cousins of anti-inflammatory monoclonal antibody therapies that are out there all fall in this category. We can also give, remember when we started, we talked about type 1 interferons, antiviral interferons. We can also give interferons from the outside. And interferons have, in fact, been shown to provide, again, some utility in SARS-CoV-2 infections in COVID-19 cases. Over and above this, for patients severely ill with COVID-19, we need nursing support. We need oxygen. We need constant turning of patients. We need breathing support. We need some amount of ventilation. We need an atmosphere of appropriate humidity. We need intravenous nutrition. We need to support their body to function while they themselves deal with both the virus and the inflammation going on in the body. That's crucial. In fact, rather than worrying about, do we have a magic bullet against the virus? Do we have a magic bullet against the inflammation? What we should be worrying about is, do we have enough hospital beds that are properly equipped, both with instrumentation, with the resources such as oxygen, and with skilled medical and even more than medical, paramedical personnel to deal properly with cases of this kind? And the short answer really so far, not simply in India, but in very many places across the world, is that we are failing in providing our communities with this. This said, let me come to the last point, which is vaccines. So, how do you build a vaccine? So, the argument is fairly simple and straightforward. We began with it. We need to get the immune system to think that it's looking at a virus. We need to get it to look at something that's not a virus, but that looks sufficiently like a virus so that it will start responding as though it is responding to a virus, and it will make the antibodies and it will make the T cells. And when it does that, we are additionally protected. An aside, keep in mind that those of us who haven't had a vaccine are not unprotected. With the vaccine, we are looking for additional protection. So how do we do this? We introduce something that looks like a virus, but that does not have the capacity to grow in the body and therefore actually cause disease. So there is a large number of ways in which we can do this. There are half a dozen different technologies to do this. Some technologies are almost 200 years old and go back to Louis Pasteur, such as simply taking the actual virus, SARS-CoV-2, killing the virus chemically or simply by boiling it or heat treating it, and then injecting killed virus. This is what the ICMR Bharat Biotech Indian vaccine candidate is. We should not be talking about any candidate that is in trials as a vaccine. We should be talking about all of them as vaccine candidates. Only when they show protective efficacy should we refer to them as vaccines. So the ICMR Bharat Biotech vaccine candidate is such a whole killed virus candidate. That's the oldest technology. It's easy to make, but it's not easy to scale up to very large amounts. And what sort of immune responses it will make remains to be tested, but that's true of pretty much all vaccine technologies. A second kind of vaccine technology is subunit, which is which exact part of the virus, which particular viral protein do we want an antibody response against. So rather than taking the whole virus, we simply take that particular part of the virus protein. We make it using recombinant DNA technology in other organisms. We make the protein, we purify the protein, and we simply take it as a shot, exactly like the tetanus vaccine shot we take, where tetanus toxoid is stuck onto alum. We can stick a viral protein onto alum and inject it, and we'll make antibodies. And that's a technology that's being tried. A third set of technologies, that's a 100-year-old technology. A third set of technologies that is being tried is, rather than taking made material from outside and putting it into the body, simply to inject the information for making these proteins into the body. I either inject it through a viral vector or through non-viral vectors. The famous Oxford vaccine is injecting information through a viral vector, a chimpanzee adenovirus vector. The famous Moderna vaccine in the US is actually simply injecting the information as RNA directly into the body. In both ways, it's the cells of the body that will make the viral protein, but again, the immune system will look at the viral protein, will respond to it, will make antibodies, and hopefully we will be protected. So quite finally, remember that the killed virus vaccine technology is 150, 200 years old. The RNA-based vaccine technology is this century, the last 20 years. It has never been licensed for any vaccine so far. So we are bringing a whole range of technologies into play for making vaccines. All of them are progressing fairly rapidly because it's not rocket science. Simply because we don't really know how to make a foolproof vaccine. What we're going to do is we're going to take the receptor binding protein, the receptor binding domain of the spike protein of the virus. We are going to put it into all these various vaccine technologies. We are going to inject them, and then we are going to sit there and wish very, very hard that in the first stage, we will get neutralizing antibodies in animals. In the second stage, which is the first stage of a human trial, this phase 1 trial, that the vaccine will be safe, it will not cause any major problems for people. In the second stage of the human trial, the phase 2 clinical trial, that it will generate neutralizing antibodies in all the people it is being tested in. And in the real test of the pudding, which is in thousands of people over months and months and months, we ask, does the vaccine actually protect people from infection in the field, from disease in the field? 6, 7 vaccine candidates are currently in phase 3 trials. Now, the newspapers make it sound as though they are in the final stages. And the reality is that the early stages are the easy stages. It is this stage that is the largest, most time consuming, and most likely to fail stage. So we have half a dozen vaccines across the world that are in these phase 3 clinical trials. And by the end of this calendar year, we should have data from quite a few of them, if not all of them. And my guess is that very many of them will show us some degree of protection. If phase 1, first generation vaccine, is not going to show us perfect protection, it's not going to show us protection for a very long period of time, and given the fact that the United Kingdom, the European Union, the United States of America have already paid money and booked hundreds of millions of doses of vaccines from a large number of these vaccine candidate makers, the question of when will any one of these effective vaccines actually arrive in India at an affordable, or more correctly, what should be a free availability, is a question for the political economy rather than for the science and technology. So that's the ambit of the virus, the immune response, and the pandemic. What can we do? Until we get a vaccine, what can we do? So number one, we need to stop behaving as though it is my individual risk and I need to protect myself from it, everybody else be damned. And the most dramatic example of this inappropriate response is the notion of immunity boosters. So everybody is familiar with the fact that there is widespread sale of immunity boosters. What are immunity boosters supposed to do? We've just discussed how antiviral immune responses in the plural. It's not one response. It's a whole set of different interlocking responses. And they don't have any preconceived intention of protecting you. They're just responses of the body. How are we going to boost immunity? If somebody tells me that I'm going to boost your immunity so that your immunity is now going to come into operation even though you're not really seeing the virus, or when you're seeing very small amounts of virus, which is equivalent to saying it might even get triggered when I'm not seeing the virus, that's going to cause inflammation without cause. Excuse me, we don't want this. Can we stop trying to boost immunity? So, please remember that immunity boosters are individual feel-goods. They are an example of consumer capitalism. They say to you, because you can afford to buy them, you're special and you will be privately protected. You don't need to worry about the community. But the reality is, we need to worry about COVID-19 as a community, not as individuals. And therefore, we need to do the tried and tested things that we already know will reduce the speed of virus spread, which is really all we want, to reduce the speed of virus spread so that our hospital systems can deal humanely, unflurriedly with severely ill people. Wear masks, any mask, will reduce transmission significantly. Keep physical distancing. Please, can we not call it social distancing? Social distancing in India, we have known for centuries as the caste system. We do not want that. We want physical distancing and social solidarity. So can we keep physical distancing? Can we wear masks? Can we wash hands to the extent that we can? This is not always practical, at least with water. For those of us who are fortunate financially with alcohol-based or hypochlorite-based or related sanitizers, but most simply with soap and water for those of us who can afford it. But at the very least, masks and physical distances. And we need to come together in social solidarity as communities, where we need to say to our governments, We need more public sector hospitals. We need well-paid, securely employed, not just doctors, but nurses, nursing aides, and community health workers. Not honorarium paid ASHA workers, but real community health workers, or more correctly, well-paid ASHA workers, because they do fabulous jobs for practically no money at all. We need to say to our government that they need to find the political will to intervene in the political economy, both within the country and globally, to make sure that when vaccines in the plural come out, that everybody gets as quick access to the vaccines as possible. This is why we need community action. We need to stop worrying ourselves as atomized individuals and start thinking about ourselves as Vasudhaiva Kutumbakam. And I will stop there and I will be happy to take questions.
Thank you, sir. Thank you so much for your nice words. And we all enjoyed your talk, sir. There are some questions from the participants. And thank you once again, sir, for encouraging us for a community protection rather than going for personal immunity boosters. And I took some questions from the participants and also I combined it.
Yes.
Sir Somnath Das and also Mr. Naseem, they are concerned about what is herd immunity and also what is the probability of reinfection after recovery.
Yeah. So remember what I said. All of us have a certain level of protection even when we have never met the virus. But such people who have never met the virus before will take a little time to deal with the virus the first time around. And therefore, the virus will have a time window in the body to establish itself in the respiratory system and to be transmitted to other people. However, if the virus comes into a person who has met the virus before and who has generated neutralizing antibodies, then I am additionally protected, and because I am additionally protected, I cut this small expansion window of the virus much shorter. Effectively, if I am pre-experienced with the virus, then I cut down the likelihood of virus transmission. So if the virus comes into a completely inexperienced community, you can imagine that it will spread quite rapidly. But as the virus keeps spreading in the community, it will begin to now come into neighborhoods where there are people who have already met the virus. And as it begins to come into those kinds of communities, its speed of transmission, its efficiency of transmission is going to drop because the people who have met it earlier either met it as a natural infection or met it in the form of a vaccine. Both of those categories of people will truncate the window of transmission of the virus through them. And as a result, virus transmission rates will drop below levels that are sustainable for the pandemic. Effectively, the argument is that if anywhere, depending on the virus, depending on the community, so herd immunity is not, this notion is the notion of herd immunity, that if enough people in the community in which the virus is circulating have become immunized against the virus, become protectively immunized against the virus, whether by natural infection or by vaccination, then the virus transmission is not going to be sustainable and outbreaks will die down. This is the situation of herd immunity, where the people who have not been infected are still unlikely to get infected simply because transmissions are not going to establish well. And this state of herd immunity is extremely variable. Number one, it will, so for different viruses and different situations, it has been argued to range from anywhere between 30 odd percent to as much as 80 or 90%. What level is required for SARS-CoV-2 is completely unknown, number one. Number two, if our antibody responses either to natural infection or to vaccination are short-lived, then 6 months later, we may not maintain herd immunity. So that also needs to be kept in mind. So with all that, herd immunity is a dynamic concept. Is reinfection possible? So far, all the reports of reinfection of SARS-CoV-2 and COVID-19 that I have seen have not formally excluded the possibility that these are artifacts. So let me put it carefully and cautiously. I have yet not seen a truly credible report of an early reinfection with SARS-CoV-2. That said, is it possible? Certainly. We have already some information that antibody responses in people, particularly in people who are only mildly infected, may be short-lived. If the antibody response is all the protection that there was, then sure, reinfection is possible. So do we know for certain that reinfection is not possible? No. But do we know for certain that reinfection is possible? No, because all the examples that are seen, that are claimed and reported, are really not strict examples.
Thank you, sir. The next question is from Mayuri. She is requesting to share some information on cytokine storm.
So I'm not sure what more I can tell you about the cytokine storm from what I've already said. As I said, you have microcontainment zones created by immune inflammation in, say, the respiratory system, in the airways and lungs. And this is great because it holds the infection there. It doesn't allow the effects to spread. But the immune system, but cells of the immune system are using chemical mediators to create those microcontainment zones of inflammation. If there are very large numbers of microcontainment zones of inflammation, if there is a lot of inflammation in effect going on in the lungs, then these chemical mediators are spilling over into the body, and then they are circulating all over the body in sufficient amounts to begin to have effects everywhere, in the brain, in the heart, in the circulation all over the body, in the kidneys, and so on and so forth. And that's when we refer to it as a cytokine storm. So a cytokine storm is when we can detect inflammatory cytokines at high levels in blood, in circulation, because that's not where they should normally be. They should normally be in microcontainment zones in tissues. So that's a cytokine storm. The way to stop a cytokine storm is to give systemic anti-inflammatory therapies. And that's what I said. Dexamethasone and corticosteroids are anti-inflammatory, and they work to a certain extent against cytokine storms and septic shocks. We never have particularly great therapies. But, for example, if the cytokine storm leads to kidney dysfunction, we can provide for some time artificial dialysis. If they lead to lung dysfunction, we can provide ventilation, and so on and so forth. So we can provide supportive therapies, we can provide anti-inflammatory treatments, and we can provide things like the monoclonal antibodies, the MABs, that specifically block major inflammatory cytokines. Although I must confess that I have yet to see any of the anti-inflammatory MABs having shown really dramatic effects in COVID-19 cytokine storm. But that's as much as I can say in really short time.
Thank you, sir, for repeating once again for Mayuri. Another question is from Akshita. She is concerned about the success rate of plasma therapy, since we know the virus, they undergo very frequently, they undergo mutation. So how successful is the plasma therapy, and what are the side effects?
So virus mutation rates in plasma therapy are not really related, in the sense that I think that the real problem with plasma therapy is not going to be virus mutation, but is simply going to be Is there neutralizing antibody in what we are transferring in the first place, because we are not testing for neutralizing antibody? And number two, how much neutralizing antibody we are giving, and is it enough to provide any protection? And number three, in severely ill people, it is, as we just said, the cytokine storm that is causing the illness rather than the virus load, and therefore trying to block the virus load may not actually be hugely useful. So the plasma therapy point, these are the real factors limiting the utility of plasma therapy, quite apart from the fact that lots of plasma is never going to be available, because how many convalescent people do you have who are in a position to donate blood? How many times can they donate blood? And we need to do all the testing and cross matching for HIV, for HPV, for HCV, for blood groups, and so on and so forth before we can do this. So all in all, plasma therapy is never going to be a large scale therapy, independent of whether the virus mutates or not. So does the virus mutate? So it's an RNA virus. Of course it mutates, but it's an RNA virus. So SARS-CoV-2 has a very large, for RNA viruses, it has a very large genome size. And one of the uses of its large genome size is that, unlike many other RNA viruses, SARS-CoV-2 has a reasonable proofreading activity for its RNA polymerase, which simply means that it has far fewer mutations than many other RNA viruses do. So SARS-CoV-2 is not going to mutate as rapidly all over the place as many other RNA viruses do. The flu viruses are segmented RNA viruses. They don't even have to mutate. They can just do reassortment of genetic fragments and come up with completely immunologically new combinations as virus strains. SARS-CoV-2 is not going to do any of these. But under immune selection pressure, will SARS-CoV-2 show us some amount of selection? Quite possibly, yes. Position 612 has been argued to be such a selected variation already. But are we currently in the hundreds and thousands of SARS-CoV-2 gene sequences, virus sequences that are being analyzed? Have we seen dramatic selection mediated by immunity, so that are we seeing immune escape variants of SARS-CoV-2? So far, no. And since in 6 months and in a worldwide pandemic with close to 20 million people clinically infected, and my guess is 4 or 5 times as many totally infected all over the world, we have not yet begun to see immune escape mutations. That means that immune escape variation is not going to be a major dominant early time strategy that will evolve in the virus, and therefore the protective ability of the vaccine is likely to be quite reasonable, at least for a while. Eventually, we will come up with immune evasion escapes, and we will need new vaccines for that. But for early time points, I don't think that's going to be a major problem based on current evidence.
Thank you, sir. Last question is from Namrata. Since you told us that monoclonal antibodies can block cytokines, similarly, can we use monoclonal antibodies against spike protein of SARS-CoV-2?
Yes, absolutely. Again, I'm so sorry. I seem not to have said this clearly. I thought I said this. An obvious MAB therapy is precisely as you say, against the spike protein, against the so-called RBD, which is the receptor binding domain of the spike protein of SARS-CoV-2. We already know there are published research papers, half a dozen different monoclonal antibodies. And it is quite interesting why they, as therapeutics, haven't quite managed to get the traction that remdesivir and favipiravir and so on and so forth have had. And I bring you back to the political economy of how drugs, MABs, VIRs, and vaccines are not simply made in the science and technology domain, but are manufactured, distributed, and made money from. And that, in all likelihood, is what is the roadblock for anti SARS CoV 2 MAB therapies. But I suspect that sooner rather than later, we will begin to see them as well. Keep in mind that even when they come up, my guess is that they will not prove to be magic bullets. They will simply prove to be modest, significant, but modest additions to therapy in severely ill people.
Thank you so much, sir. Due to time constraints, we are not taking up all the questions from the participants. We are really sorry. Thank you, sir. Thank you so much for answering all the questions. I hope all your valuable inputs will benefit the participants, especially the students, and motivate them for future research. Now it's time to say vote of thanks. We would like to thank our principal ma'am for her constant support in all our academic endeavors. I extend my sincere gratitude to our guest, Dr. Rath, for his informative and relevant lecture and sharing his knowledge. Thank you, sir, for taking out time from your busy schedule to encourage many students here. Thank
Thank
you
you
for
very
giving us
much.
this opportunity to interact with you, sir. Thank you
Thank
so
you
much.
very much.
We are
Thank you
extremely
all, and good night.
Thank you, sir.
Thank you so
We are
much.
extremely thankful to all our senior teachers here and Sashi ma'am and also Smriti Sharma for being part of this seminar. I thank Mr. Ranil for his technical assistance. My sincere thanks to all the participants for their questions uh, and their presence and also for asking interesting questions. Thank you, one and all. Thank you so much. Good evening.
Thank you, and good night.
Good night, sir.